We don't have a Q&A session in here. We will have a Q&A session together after we have a breakout session. And then you may find your assigned group number and venue by the stickers on your... Yeah, sure, go ahead.
Apologies for jumping in, because we have to relieve the venue at 1 o'clock, and we don't have time to break out. Instead, what we are going to do is I'm going to run through the cases, and since we have a great audience, the format I'm going to follow is I'll present the case, and maybe we'll get a medical person to comment, a person from the legal side to comment, some opinion from the experts, and then each of you has a green and red card, so you can chip in your voice as well. And that will allow also a Q&A session with the confidentiality. Otherwise, I'm so sorry, we don't have time. We have to release this venue at 1 o'clock. So originally, each group, we had 4 groups. I think we were a bit ambitious, but we can still carry on the discussion in the later part. So we're going to start by presenting facts of some cases. Some of you may recognize these cases. They have been anonymized, or they may look very similar. First, let's begin with the facts of case 1. Mr. B. J.K. was a retired businessman. He was referred to a surgical unit for a cervical lymph node biopsy. A doctor examined him, let's call him Dr. X, and booked him for a neck node biopsy. This is how the lymph nodes in the cervical region or the neck look like. And the biopsy was scheduled for a few days later. As we all know, in practicing doctors in the hospital authority, one surgeon sees and somebody else does that. This was the 3rd biopsy. The patient had had 2 prior biopsies in other hospitals within the past 3 years and on the same side of the neck. So here's how a lymph node biopsy looks like. It's an incision. There are some important nerves and vessels. What actually happened? Dr. Y performed the biopsy, after which the patient was discharged. He followed up a week later complaining of shoulder weakness, and what had happened was the accessory nerve was damaged. It was clinically confirmed after a couple of investigations. In fact, initially it was not even recognized. It went off as shoulder pain. What are the problems that we want to discuss? First, the risk of nerve damage was not disclosed. Dr. Y said that he was only performing the biopsy as instructed by his seniors. They should have disclosed the pertinent risks. Dr. X said that the patient had told him he was aware of the risk as he had undergone similar biopsies. In fact, what happened was the patient said, yeah, no, don't need to tell me anything. I've had 2 biopsies, get me a date immediately. Key questions that are in front of us to discuss. What is Dr. Y's role in informed consent? Does Dr. X have any responsibility for informed consent? And eventually, because there is an economic redressal for the failure, who is culpable and liable? Shall we get one of the clinicians to comment, please? What is doctor's role in informed consent? I don't want to call Philip because he gave a talk on informed consent. So I said I don't want to ask Philip because you gave the talk on informed consent. I want somebody else to. Danny.
It's a very difficult question. I think Dr. Y, first question first. I think Dr. Y, as the operating surgeon, he has the duty to obtain an informed consent in the circumstances. Whether Dr. X has also the responsibility for informed consent, I don't know the role of Dr. X in the scenario. I believe this case is special because the patient needs to have 3 biopsy down the road. So I think if Dr. X is the attending surgeon and perhaps the senior or whatever, he should have the responsibility to inform about the everything.
Quickly, before getting out into the, getting lost in the technicalities, the first biopsy was done somewhere, was inconclusive. The second biopsy was also inconclusive, but the pathologist said that the specimen was not, they may not have been representative. So this was not a technically difficult situation. This was just, patient was frustrated. There was probably some sort of resistant TB. He wasn't getting the answers, and there was a requirement for doing the biopsy. And therefore the question is, what is the role of Dr. X who ordered the biopsy? And for people who may not be very familiar with the healthcare environment, in public hospitals, some of the arrangements are you have a minor surgery or a minor operation, a doctor books it because you see the patient in the outpatient, and somebody's assigned to do the surgeries. The patient walks in, it's a daycare or even a walk-in, and the person looks at it and says, okay, let's do a biopsy. So that's the situation. So.
Well, who is accountable if this patient receives treatment at hospital authority's hospital? Hospital authority takes the blame.
No, we have not yet come to the blame. We are just saying, what is Dr. X's responsibility? Shall we move on to, yes, there's one hand up there.
My background is a nurse, so I don't do politics. So I think for me it's quite easy. Whoever gives consent, like signing consent form, should disclose all the possibility to the patient, and whoever does the surgery should actually check if the patient is being fully consent. And if you ask me the last question, who is how do you say that? Like, responsible, I think they both held the same responsibility. But to some extent, I think whoever does the surgery actually probably should hold more responsibility, because after all, they are the one actually perform the surgery. And for people to think just because the patient had 2 previous biopsy and the patient said, oh, don't tell me about it, I know everything is like that actually means nothing. Because if it's not written down, it didn't happen. That's what I've been told. And the other lessons I've been told over the last 20 years I've been doing nursing is trust nobody.
It's very good, very good. That is very good. One more comment before we move on to the legal experts in our panel.
I think the doctor explaining the consent form should be more responsible. Firstly, because most of the consent will have whole list of risks associated with the procedure, we should adjust the content of the explanation according to patient's knowledge and previous experience. For example, in that patient, he had plenty of previous experience in undergoing this kind of procedure. We can try to simplify the explanation, but we still need to explain the salient point of the risk. For example, say, instead of explaining to possibility of damage to particular nerves, we should at least explain to the patient that may have possibility of spraying some important structure around the operating site, for example, blood vessel, nerves. So I think the doctor should adjust the explanation procedure, but still need to keep the important point in the explanation. And for the operating surgeon, probably at least he need to check that the patient have undergone such procedure, and just say a simple question about, do you understand the procedure? Do you have any questions? And that sort of questions.
Okay, good point. We're going to move on because we have a couple of cases. So originally we had this group representative's view, but because of shortage of time, I'm going to tell you what actually happened. And then we have 1 or 2 questions again. So Dr. X maintained that the patient claimed he was aware of the risk and he did not think any further explanation was wanted. And again, once again, I have to tell you, I actually agree with what you've said and what you've said, but practically in a team-based, is the junior most who's been relegated to do the smallest surgery. So maybe Y, who did the surgery, wasn't experienced enough to understand the full impact and the full extent of disclosure that was required. And Dr. Y admitted that he was inexperienced, that this was going to be only his second lymph node biopsy. So the case was settled outside for an undisclosed sum, which means a very large sum. And again, I want to remind ourselves that the institution, there are cases that can be held liable for doctors who are not credentialed for doing particular procedures, as well as in Goldberg versus Boone. It's very interesting, the doctor's inexperience meant that proper informed consent was lacking, and therefore I really appreciate Philip's talk in the morning saying that the top dog in the team has to take responsibility for making sure consent is properly explained to the patient. Do we have any questions? Maybe one question from our panel of legal and academic luminaries. Otherwise, we move on to the next case. There are some fascinating cases, and case 2. It's getting quite interesting. So MK is a temporary migrant to Hong Kong. He has 2 children, both male, aged 18 and 5 years. The 5-year-old was born in Hong Kong. The family is due to return to their home country following their 6 years in Hong Kong. And the father wants the second child to undergo circumcision for religious reasons. You're a general surgeon and agree, but you want to inquire with the child. The father refuses on the basis that parental rights stand in the light of well-established religious beliefs and practices, and that the child should really have no say in the matter. He does not want the child to know beforehand. He says after the procedure, the child will know anyway. The father also states that circumcision in Hong Kong is preferable, as if it is done in his country, it will be done the traditional way and usually without anesthesia. He suggests a number of ways in which the child can be deceived rather than coerced, such as deep sedation the night before, maybe a peg. Key questions. Would you agree to performing the surgery without the child's prior knowledge and agreement? On what ethical principle would you agree or refuse? And what do you think your action would be if you are going to act in the best interests of the child? So let's go back to the clinician. No, mind you, we are not discussing the ethics of circumcision, because that's a huge topic in itself. We are just discussing what the general surgeon should be able to do. A quick one. Simon, maybe. You would be an anesthetist. You have oversight over surgeons.
You want to change my role from an anesthetist to be a surgeon? I think I would suggest the child to be given anesthesia.
No. The child is going to be given anesthesia because he's 5-year-old. Yes.
The second boy, right? That is the 5 years old.
He's a 5-year-old, yes.
So not the 18 years old.
I'll tell you the significance of the 18-year-old a bit later, but I
Okay.
haven't. I'll tell you.
I think, well, perhaps from a clinician's perspective, I can answer question C better, because what is the best interest? Now, circumcision is irreversible. It was done for religious purpose, as you mentioned.
Yes, it is done.
That is not for medical ground. I think it's very difficult.
I know. That's why we are discussing it.
What encompasses best interest for this particular trial? As a clinician, I always perform circumcision for medical grounds. Religions, whether that is also fall into the category of best interest, I'm not too sure. Yeah.
Any takers on this?
Yeah,
Yes.
I mean, as a practicing psychiatrist that sees children, obviously the child has to be spoken with the parents in the presence of the child. I mean, you know, if you're going to see the dentist, the child, before the dentist puts the drill in his mouth, will presumably tell him what's about to happen. So I think at some level it's as simple as that.
What if the, I mean, here the difficulty is that the parent says no need to talk to the child. So that is, but I fully appreciate your point.
Then the doctor takes legal advice.
Okay, one more question, one more.
I'm sorry, I disagree. I think the kids definitely needs to know what's going on, despite what the parent says, because again, I'm a post-anesthetic care nurse, and if you don't tell the kids what happened, regardless how wonderful your anesthetic is, the trouble we are dealing in anesthetic room is ridiculously compared with the kids knows what's going on versus kids actually being cheated going to surgery and wake up in post-anesthetic care unit. It's magnificent difficult. It's very difficult to manage. And what happened is that none of you guys will be there to deal with that because you've done your job already. So considering it's not what you guys do before the surgery actually has an impact on what the kids will behave after the surgery as well. So I think first question, if you think from post-anesthetic and post-surgery care perspective, you actually need to tell the kids what's going on. He's 5 years old. He's not like an infant. He doesn't know what's going on. The kids actually, the level of their understanding sometimes is like it's more than what we think they know. They probably know more than us. And also, on an ethical principle, I still think the kids should know because we should respect, even though they're kids, it doesn't mean they're not human beings. If they are human beings, they have their right to know that. So I'm begging all the surgeon and all the general practitioner think for nurses' perspective, what your behavior and your action can have a huge impact on us after the surgery.
Okay, the difficulty, the difficulty is agreed, the child should know, but the parent said, no, I'm not going to allow my child, so no general surgeon will operate, and then I'll have to go to my home country, and then nobody's going to listen to the child. It'll be done in a traditional way, no anesthesia. So the dilemma here is, on the one hand, what is the best interest of the child is to get a circumcision done here without the child's knowledge. So, but we agree with your point that also causes irreversible trauma because there's a betrayal of trust. And the question is, how do we address this? And for that, I think the philosophers should have some answer on.
I would have thought that the parental consent and decision is a necessary but not sufficient condition for deciding whether that's the thing to do. And in order to answer that question, whether circumcision would be in the best interest of the child, that question has to be answered. And in order to answer that question, we have to assess whether that is in the interest of the child from a medical perspective. So I don't think we can answer that question apart from whether circumcision is in the best interest of a child or not. And simply because the father says, you know, if you don't do it here, we will do it in our home country. I think that is almost like coercion. So I don't think that the doctors should say, oh, okay, then I'll do it. I don't think that would be, okay.
Huso, one last one before.
Well, you know, I'm originally from South Korea, and you know, the circumcision rate in South Korea is quite high. That almost about over 90% of male will get circumcised. So this is my case for discussion. I'm happy to see that, oh my God, this is talking about me. So I'm a victim of a circumcised person. But I guess when you talk about the individual best interest of child, I'm not quite sure whether we could really do that, because I mean, maybe that person, even though the child say no, he will be part of the culture, the region that will force him to be circumcised. In that case, I'm not quite sure that whether we could really ensure, or the child could have his own interests will be fulfilled within the region, that he might be ending up getting circumcised in a country where that maybe sometimes the unsafe procedure will happen that will cause more damage to the child. So then I can't just say that, oh, we need to really look at the child. Then maybe not, because he will be moved to the other country. Then everyone gets circumcised. Then he can say no. Then he will get full circumcised. That will lead to maybe unsafe circumcision. Then what's the best interest of child in the future? Possibly getting safe circumcision in Hong Kong will be more beneficial to get an unsafe circumcision in the country.
Okay.
I have two sons, one of whom has been circumcised at his choice for non-medical reasons, the other of which has not been circumcised. His mother wants, for her cultural reasons, him to be circumcised. I refuse. I think the answer to the question here is a child should not be circumcised for non-medical reasons unless it is clearly that child's own decision. As to the fact that the implicit threat that the father will have it done under less than ideal conditions abroad, okay, if daddy wants to issue threats, then make the legal profession in Hong Kong richer and make the child a ward of court.
Okay, point taken. I'm going to, again, this is a very interesting and personal case because the child was playing piano and studying with the same piano teacher, and I knew his father very well. So what actually happened? Of course, the surgeon, which wasn't me, but a close friend, refused to oblige on the basis that it would be ethically unacceptable. And as rightly pointed out, it was better to counsel the child because of the inevitability of getting a circumcision under a very strong religious background that the family came from. Now, we can debate that, but I think in some circumstances, people and patients and children have very limited choices, and therefore, within those limited choices, I think we are obliged to see what is the best interest in those circumstances. So I would say that the father was not threatening the surgeon, so that's not probably the way, maybe it comes out that way, but certainly it raises significant questions, and eventually the child agreed. The child was a very bright and knowledgeable kid. In fact, given the circumstances, he probably may have been coerced in a different way, but eventually he agreed and the circumcision went on. But good points to discuss because we can have a whole issue on parental consent, and I just want to let you know that the 16-month-old child had a gender reassignment or a gender assignment, was born hermaphrodite, and the adopted parents are actually suing the hospital because the child was made a female, and the child actually wants to be reared as a male. Extremely complicated case in the US. We have one last case, very interesting. We actually have maybe two more we can discuss. Mr. Yip was scheduled to undergo hernia repair surgery. A senior surgical, this might be of good interest to the students, a senior surgical resident was explaining to two final year students just prior to scrubbing up, do you think an enlarged prostate may have predisposed to hernia? And asked one of the bright students. Most likely, said the registrar, have you felt an enlarged prostate on per rectal examination? No, but we would like to, as the patient is already under anesthesia and won't be discomfort, said the students. So registrar asked Mr. Yip whether it was okay for the students to do a PR examination, and Mr. Yip nodded in agreement. And as the students were getting ready, there were some key questions. You are the nurse in charge of the OT. And would you allow the students to proceed with the examination given that this is an important skill for them to learn and that the patient has agreed? So let's ask the nurse. Sorry, the patient under spinal anesthesia. Yeah. Usually there is, depending on how chatty the anesthetist is with the patient.
Yeah, I need to ask the anesthetic because the spinal anesthesia versus spinal with sedation will actually change my answer.
It's spinal
Because
no
if patient
sedation.
just had pure spinal and he's alert, he's orientated, his mental state has changed, and he actually is agreed, I think that's okay. But if the patient had a spinal, on top of that he has some sedation, then no. Even though he nod his head, it doesn't mean he's actually give the consent, because his mental status has been changed under the influence by the sedation drug.
Anesthesists. Actually, when I was in training, I would often ring up my boss, and even sleepily he would say, do this, do that. So I think he was sedated, and I took his answer for always, all of us were.
For spinal anesthesia, basically the patient's level of consciousness will not be altered. So meaning that the patient will remain, have a mentally sound, able to make a decision to accept or to refuse a parectal examination. But I think there is much more issue in relation to this apart from the spinal anesthesia.
I mean, we heard from Philip that you got to be in a good environment. So here's spinal anesthesia, patients like that, and the hand is here, there's a drip, something, and then you ask, should I do this? And the poor guy says yes. So do you think that's valid consent?
Yeah, I think this is a very important issue, that he is due for a surgery, and at that time, there's something added which is outside the surgery, and he is obliged to do it before his surgery, then he's in a threatened environment to make his consent.
How dare you say no is the implied threat, isn't it? Do we have any comments?
I think for consent to be valid, the patient needs to be under no pressure. So we didn't know, because he's already on the table. He didn't know the consequence of trying to refuse the examination. And I also want to ask about the surgeons. What if they just do the PR after the hernia repair? I think it should be the same.
I think in the operating theater, we should be doing something that is indicated for the surgery. So, and it's to the best interest of the patient. So if that procedure is not totally necessary in a medical indication, then I think it shouldn't be actually done for that particular procedure. So we can do it after, when he awake, and in the bedside in a comfortable manner, and the patient's not threatened, and then you can teach the student. That's okay. Yeah, of course.
Yeah, one point.
At the other end of the age spectrum in psychiatry, can I make a plea for sort of liaison psychiatry? I mean, the 77-year-old statistically, and we've heard about the dangers of statistics, it's probably got about a 1 in 4, 5 chance of having some sort of dementia type illness. If it was in the United Kingdom, you know, the beds are full of people with dementias undiagnosed, a great problem. So there is an issue about capacity here. Who's making that determination with this man on a bed at that point, at that age, in some sort of potentially compromised situation? So the big picture here is that we're talking about consent and informed consent, and a lot of people, especially elderly people in hospitals, there is an issue about their mental states and their capacity, and we are not systemically considering that or managing that. A bit like X and Y, the system is set up to fail. A root cause analysis would say, you've got to change your system.
It's a good point. I think because we have the one more case to discuss if we break up, the actual case scenario didn't involve the Mr. Yip with the hernia, but it involved a difficult insertion of a Foley catheter in a patient scheduled to undergo a major procedure. Just before major procedure, we put in a urinary catheter, and that was difficult. So he was under general anesthesia, and the surgeon performed the PR examination to check on the prostate. It was an enlarged prostate. That's why the catheter was difficult. He may have had symptoms, but it was not penetrated before. Then 4 other medical students who were there also gleefully examined the obvious enlarged prostate as they were instructed to, because that was important. Upon recovery, the patient was a bit perplexed as to why, apart from his knee pain, he also had anal discomfort. Then the need for PR examination and catheterization was explained, but the part of the students was conveniently omitted. last case, which is actually quite interesting, and I would value the opinion of the luminaries from the legal profession. Mr. Chan was 55 years old. He worked in a bank, was a regular patient at the GOP government clinic, had a history of multiple aches and pains, complained of increased severity of hip pain, not responding to analgesics, and insisted on an orthopedic referral. Then a specialist saw him at the orthopedic clinic, ordered a battery of investigations such as X-ray of the hip, routine blood and urine examinations that happens every Thursday afternoon in the general clinic. A lot of similar patients approach. There's a routinized method of examination, etc. So that was the X-ray. At subsequent follow-up, the doctor reviewed Mr. Chan's X-rays and diagnosed osteoarthritis. He was advised medications, physiotherapy. Blood reports were normal. The urine showed some hematuria indicated as 2+, and the doctor inquired about urinary symptoms. There were none, so the result was not disclosed for fear of causing unnecessary alarm. Key questions. Is disclosure of abnormal or borderline test results that may not be directly related to the patient's presenting complaint obligatory? He wasn't complaining of anything urinary. He had no urinary complaints. What ethical principle governs this? Should we or should we not disclose? And are we therefore expected to disclose trivial abnormalities? And how do we proceed? Again, a quick surgeons, anybody? Physicians, yep.
I was a general surgeon. I think in this case, the urinary test should be repeated sometime later. So on that basis, we have to inform the patient what we found and the justification for doing that. That's all. For the limited information I have, this is the only comment I have.
Very good point.
Being an anesthetist, we have every now and then, we at the peer anesthetic clinic, we pick up a few hypertension, heart failure, murmur, a few other things, and then we refer the patient to the appropriate specialty. And I think it was from our point of view that the patient who have any abnormal findings that should be disclosed to the patient and doing an appropriate follow-up.
One more.
If you do the test, whether you're an anesthetist, surgeon, whatever, you're obliged to share the results with the patient, normal, borderline, or abnormal.
Actually, what really happened was the test results were done somewhere, some other hospital, and then he gets referred to the orthopedic specialist outpatient. But I fully realize, I fully appreciate, I think also appreciate that it's a borderline, it's not significant, it's not related to the original complaint. So it's a prudent clinical decision whether or not to repeat the tests. Again, the ethical underlying principle is you want to do no harms, you want to do good, so it's beneficence, and I think once again as autonomy, patients need to know and let them decide if they want, if there's cost cutting or there's a care rationing, they need to know because you may repeat the test. Anyway, I'll tell you what happened. Mr. Chan's hip pain progressed. He was considering surgery for his hip problems, but he decided to wait till he could make some arrangements at home. A few weeks later, his pain became unbearable, and he went to the emergency department of another hospital, and the radiographs actually showed he had a destructive lesion in the pubis. And you could see within the 6 weeks, the front of his pubis had completely disappeared. In fact, what he had was the beginning of hematuria from a metastatic bladder carcinoma. And the patient eventually passed away at home because of massive bleeding. And the family filed a complaint against the doctors and the hospital for negligence and for failure to disclose material information upon which the patient could have acted and could have done something. Whether, of course, his life would have been saved is another matter, but that case was... Do we have any questions? We have, I'm afraid we've come to the end of our morning session and we need to break out for lunch. If not, thank you very much.
Thank you, Professor Kumta, leading us the discussion. This draws the end of the morning section. We have prepared a packed lunch and they are available at the foyer area now. The afternoon session will begin at 2:30 at 2 at the lecture theater 6 on the second floor. Please bring your belongings with you as you are not using the same lecture hall in the afternoon. You may reach the venue by the elevator on your right or taking the stairs. For those who are joining the morning session only, we are very grateful if you could provide us your opinion by filling out the evaluation form attached in the program book. You may return the form into the registration desk. And one kind reminder to participants who applied for professional accreditations. Please remind to sign on our attendance sheet and keep your training record. Enjoy your lunch.